Well, I think at the meeting there have been a number of very important debates. I mean, I think the immunotherapy discussions are fabulous. I mean, I think that's the other point, is that there's so many new treatments, there's so many new immunological strategies, there's a whole constellation of different options. And so in that context, philosophically, we've got multiple therapeutic strategies available, which is great. In the immunological space, we've seen some fabulous data in antibodies. Not just CD38 targeting antibodies, but most interestingly, the use of antibody-drug conjugates. An absolutely beautiful presentation today, which I thought was particularly informative actually, regarding the antibody-drug conjugate. We call it Belamaf for short. It's GSK 916, and I think that was a particularly emblematic of the new wave in immunotherapy, because the use of this antibody-drug conjugate has been really quite remarkable in terms of its response signal in even the most advanced patients. And I think that in that group of patients where there's exquisite medical need, BCMA is targeted with a cytotoxic payload, in this case auristatin. And in that context we're seeing great responses, manageable toxicity. And I think the combination data are going to be phenomenal with that particular approach. So I thought, to my mind anyway, that was a particularly exciting part of one of these sessions on new approaches immunotherapeutically, including antibody-drug conjugates. And then I think on the flip of that, there are other drug strategies that are being developed that are really very promising. And one of them includes the use of a targeted chemotherapeutic called melflufen. It's been my privilege to be part of the work in this space. And what we're seeing is that it's kind of a very new approach to an old concept. Obviously melphalan's a wonderful old workhorse. You know, it's been with us for 40 years, more actually. One goes back to the 50s when it was first developed, but certainly as a transplant conditioning regimen, it's solidly 30 to 40 years of work, of support and being therapeutically very effective. As we move into the new era, a more targeted and arguably less toxic approach with cytotoxics is very important, and melflufen may fit that bill. And we're presenting at this meeting data showing that even after all other classes of therapy have failed, including CD38 targeting, we're in a position to target in particular extramedullary disease, which is a real challenge. And in that space, melflufen has shown some very promising single agent activity, recognizing that's a particularly difficult subset of patients to treat. What's also important is in that subset, actually, we're realizing that subset's growing. That unfortunately extramedullary relapse, as patients live longer with myeloma, appears to be increasing. So the need for novel agents that specifically go into that space is very important. And melflufen may be one that not just on its own, but most importantly in combination, may have that role. I would just simply say that the International Myeloma Workshop, I think, has been so informative with lots of different things, and it's a lovely opportunity to sit down with preclinical colleagues and clinical colleagues and interface to really bring forward such a lot of incredibly interesting information. And I'm just thoroughly looking forward to the next one, which is going to be 2 years in Austria, as I understand it. So obviously continued progress.